Good afternoon, everybody. It's really my honor and privilege to greet a good friend and colleague, Dr. Jeannette E, to join us today to commemorate our Juneteenth celebration. And I took my mask off to do introductions, and then we'll put it back on. And Dr. Southpaw is going to also remove her mask to do her address with proper distancing. Much easier, I think, for our recording, and also to make sure the microphone picks up her remarks to us today. Dr. Southpaw was the Andrew Matheson UPMC Professor and Chair of the Department of Family Medicine of the University of Pittsburgh School of Medicine from 2001 to 2020, retiring in 2020, although I don't believe she's retired at all when I hear what she's been up to. Prior to joining the faculty of the University of Pittsburgh School of Medicine and UPMC, she served as Medical Corps Officer in the U.S. Army, retiring in 2001, while serving as Chair of Family Medicine at the Uniformed Services University of the Health Sciences, and previously as Vice President for Minority Affairs at the same institution. Dr. Southpaw was responsible for the educational, research, and clinical activities of the undergraduate and graduate medical education, faculty practice, and community arms of 3 family medicine residencies and 7 ambulatory clinical sites in Allegheny County, Pittsburgh, and responsible for the academic missions of 5 additional UPMC family medicine residencies throughout Pennsylvania. She is a family physician with specific interests in the areas of cultural competence, maternity care, and health disparities in the community. She designed an investigator-initiated project to evaluate the cultural aspects of contraceptive choice that has been active since 2017. In addition, Dr. Southpaw has served in leadership positions in the Society of Teachers of Family Medicine, the American Academy of Family Physicians, the Association of American Medical Colleges, and the Association of Departments of Family Medicine, to include serving as president of the Uniformed Services of American Family Physicians and the Society of Teachers of Family Medicine. She was elected to the Institute of Medicine, now the National Academy of Medicine, in 2011, received the University of Pittsburgh 225th Anniversary Chancellor's Medallion, and was elected to the Gold Humanism Honor Society in 2015. As well as receiving the Allegheny County Medical Society Dietrich Humanitarian Award in February of 2018. She is a sought-after speaker by academic, clinical, and community organizations, as well as health industry groups who are seeking perspectives on health disparities, workforce diversity, and racial and social justice. Without further ado, please join me in welcoming Dr. Jeannette Southpaw.
Thanks so much for inviting me. Thanks for coming. I know this is a busy time for all of us, and it's a time of transition, so thanks for allowing me to present without my mask, though I am immunized, and I trust and I'm sure that most of you are as well. But it's because we all have this sense of the importance from a public health perspective of taking care of those we love and those with whom we come in contact. So it's good for me to be here to see old friends. Thanks so much, Doug and Brad and Kezia and folks that I know, because you know it's a small world. It's a small world. And what affects one of us affects all of us. And I think that's why it's my privilege to be able to talk a little bit about this Juneteenth and what that actually means. You know, in 2016, at the age of 89, a former teacher named Opal Lee walked 1,400 miles from her home in Fort Worth, Texas, to DC because she was trying to get Juneteenth recognized as a national holiday. And I'm sure you've heard, as of today, President Biden has signed off after both the Senate and the House of Representatives have declared this indeed a federal holiday. We will see how it is embraced from state to state, because there are certain states that were already celebrating it. But the goal will be that it will be embraced and recognized for its importance nationwide. What is this? Well, June 19th, 1865 is the date that we're talking about, this day in history. And it was a time when it's been called a number of things, Freedom Day, Jubilee Day, and a lot of other names. And it's a time of recognizing past injustices. And so it was the day that even though General Robert E. Lee, Confederate general, had surrendered at Appomattox Courthouse in Virginia, slavery actually remained unaffected and continued for another 2.5 years in the state of Texas. So Juneteenth is the day when General Gordon Granger, a Union general, brought federal troops and stood on Texas soil and read General Orders No. 3 to take control and ensure that all enslaved people would be free. His exact wording said that, he said that I am addressing the people of Texas. And actually, I was in Texas up until Tuesday night. So I assure you, Texas considers itself a unique, different, and a country unto itself. But General Granger came to say, you must release these slaves. The Emancipation Proclamation is more than 2 years old. And not only must you release them, you must recognize equality of personal rights and rights of property between former masters and slaves. If the slave continues on the plantation where he or she was previously a slave, they should be paid for the work that they are doing. And they wanted this to happen because they didn't want the slaves to all leave en masse. Because you realize that the slave labor that was ingrained in our country for so many years was actually the anchor of the economy. And so they were told they didn't want them to go to military posts, they weren't going to be supported for idleness, they were to stay. So this should have been a wonderful day, and it was a day of celebration. People went and got together and celebrated together. It would be nice to think then that everything changed. But indeed, what happened was the Emancipation Proclamation was signed. General Granger came to Galveston, but not much changed. And you'll say, well, gosh, but it was still a special time, wasn't it? There actually are other events where there were previous celebrations of the end of slavery, starting with, believe it or not, Haiti. Haiti was the first black republic in the Americas in January 1st, 1804, after the Revolution, where they declared slavery illegal. There were other celebrations in 1808 where they said that the transatlantic slave trade was no longer legal. I bet most people don't realize that. Now, that didn't mean slavery entered the United States. It just meant that it was no longer legal to bring slaves from overseas, but it continued to happen sub rosa. And so that meant that even though there were these different times of celebration, it didn't actually get implemented amongst those for whom it was most important, black people. And then there was a formal Freedom Day celebration in 1827 because New York formally abolished slavery. And they wanted to celebrate it on the 5th so that it wouldn't get mixed in with the regular Independence Day. And then slavery ended in 1834 in the West Indies. Those of us who have West Indian background realize that slavery ended there earlier than it ended in the United States. But again, it didn't guarantee equality for those who had been enslaved. So why is Juneteenth such an historical time of celebration? And why is it significant today? And I think the thing to keep in mind is it draws attention to the fact that many things were put in place to continue to subjugate a population that had been here as slaves. Okay? Jim Crow practices, things about not allowing blacks to ride in train cars where whites were riding, not being allowed to live in neighborhoods that others have, not having equal justice. All of those practices started to emerge around the 1870s and 1880s. There was aggressive neglect of black schools, such that their black students could not be in the same school as white students. I had the privilege of giving the 50th anniversary plenary at the University of Alabama. And I was invited by a colleague of mine who was the dean there, and we had been colleagues and family members for a long time because I was born in Hale County, Alabama, at a time when, dating myself, when black women were not allowed to be delivered in any hospital south of Birmingham. For anybody who knows the topography of the state of Alabama, Hale County is a long way from Birmingham. It's more than 100 miles. And so at that time, if you had to find somebody who's willing to deliver you, or else a lay midwife or relative would deliver the woman. My mom was an immigrant and had just come and heard about this old elderly white general practitioner named Dr. E.T. Norman, who would deliver black women in his office. And so I was delivered in Dr. Norman's office on his exam table. And then he would have the woman, my mom, go into his waiting room and lie down on the couch till he could be certain that she wasn't bleeding anymore. He didn't have IVs and all that kind of thing to make sure everything was okay. So for me, recognizing that times were changing is really important. It's a part of my history. And I actually had the privilege on a military rotation one summer in medical school, driving back from Oklahoma to come close to the town where I was born, Greensboro. And I just took that chance and went to the one phone booth in town. Yes, there still were phone booths at that time. And opened it up and opened up the phone book and found one Norman in the phone book and said, hey, put my quarter in and dial the number, and got this clearly frail elderly voice in the phone. I said, are you Dr. Norman? And he said, yes. And I said, can I come see you? I think you delivered me. And it was one of the most amazing experiences of my life. And I got a chance to sit down with this man in his 90s, telling me about his experience as a GP delivery. And he had an album of all the black kids that he delivered, along with white kids too, but all the black kids he delivered, and how, when he heard I was a medical student, he was just unbelievably thrilled, thinking that he had contributed to that. So you see that, in spite of all this, there were good people interspersed within, but there wasn't much support from the structures and institutions in the community at that time. And then, of course, we know of the rise of mass incarceration because of the injustices of the justice system, such that it took very little for a person with melanin in their skin to be in prison. And the ongoing trauma that we see today of violent policing in our communities. All of these things started to emerge after the Emancipation Proclamation, and starting in the 1870s and 1880s. And you might say, well, that was a long time ago. But then, not even 70 years later, you will recall, because we just hit the 100th anniversary a couple weeks ago, of the Tulsa Massacre. That occurred at a time when a community had gotten together, an African-American community in Tulsa, Oklahoma, to actually what was called the Black Wall Street. They had multiple banks, they had businesses, they had schools, they had everything imagined, about 80 square blocks. And because a 19-year-old black kid was accused of assault, a mob, which was not just a mob of intransigents at all, but a mob that was supported by the law enforcement. Law enforcement from that community and surrounding communities came and attacked, burned to the ground the entire Greenwood community, and killing more than 300 people. It was called one of the worst acts of domestic terrorism in the United States. Not just 100 years ago, long after the Emancipation Proclamation. And actually, there was no governmental investigation of any of these events that occurred at that time. The first governmental investigation of this massacre occurred in 2001. And it was thought to be ethnic cleansing, is what it amounts to. And even if this young man had done whatever they thought he did, there was no justification for what the murder and looting and arson that was inflicted upon the community as a result. So most recently, an African-American Oklahoma State representative came to speak on this whole issue, whose grandfather and great-grandparents survived this massacre. And she said, what people don't realize is when those things happen, you lose people, you lose generations, you lose generational wealth, and you harm people's ability to dream because they can't see that this is actually possible for them. The business district, which had been so thriving, which was reduced now to what is today, one block of gentrified catering, mostly to the majority population. And to this day, they have been digging up mass graves that have been dated back to that time, that had never been revealed, people who were never actually given an appropriate funeral law because no one wanted to acknowledge what happened. You might say, well, that was 100 years ago. But what about 2 weeks ago? I'm sure you all heard about Army Lieutenant Colonel retired Captor, who was invited to do a Memorial Day presentation, not in Tulsa, not in Hale County, Alabama, in Hudson, Ohio, and at an American Legion post. And they came back, he said, I'm going to give you my script in advance so we know when I'm going to speak. I didn't give anybody my script in advance. But anyway, I'm going to give you my script in advance. And they said, take out all that stuff about the contributions of black people to the military. We don't want that. And he thought about it and said, wait a minute. This is a Memorial Day celebration, and needless to say, I take this very seriously as a veteran myself, and having 2 active duty Army sons, both of whom were overseas at the time. He says, oh no, we don't want to hear about that stuff. So when he came, but he refused to take it out. And when he came to that part of his presentation, they turned his mic off. And they turned the mic back on 4 minutes later when they figured that this was just about done. Because they thought that he was trying to rewrite history, and it wasn't appropriate. So I'm saying this to say that one of the implications of Juneteenth is that bad things happen then and continue to happen in one shape or form, and we cannot ignore this amount of history. I don't care what you call it. There are a lot of people saying we don't want to hear about certain terms like critical race theory or whatever you want to call it. This is history. And it is, what does the sentiment say? If you don't acknowledge history, you're doomed to repeat it, right? So I say this because it then becomes clear that the pathway, the journey, is not the same. There may be the same distance, but the obstacles that are there make it more winding and make it much more difficult for those who have not had the experiences of privilege. And these translate into health disparities that those of us who are committed to healthcare see. Health disparities are that difference in health status among distinct segments of the population, and they occur because of race, or gender, or ethnicity, or income, or just where you live. We know there are health disparities that we can identify by zip code and census code. And then inequities are when you see those disparities, specifically as a result of systemic, avoidable, and unjust social and economic policies and practices. So there are disparities sometimes because of exposure to environment. There are disparities because of how much money we make. But when these disparities are because of inequities that are systemic, that are institutional, then we know that that is a major issue. Now you might say, so what do you mean? Well, studies have been done about the care that's delivered in certain hospitals. And there have been some really good studies done to basically say that you find that there are substantial decreases in quality indicators from minority populations versus majority populations around. And they measured things like acute myocardial infarction, congestive failure, and community-acquired immunity. And they could see the difference, distinct differences between hospitals. So it's critical when we work in an organization to say, how do our quality indicators not just look as an aggregate, but how do those quality indicators look depending on the demographics of the population we serve? And so it was interesting because so often you've heard a lot lately about this, also because of maternity month that recently passed in the last couple months. And so there's one study, and this was done by Elizabeth Howell, who's currently the chair of OBGYN at the University of Pennsylvania. And she's made really focused on maternal mortality and morbidity disparities between African American, Latino, and white American women. And what she found was that she looked at race, ethnicity, medical insurance, because we know insurance is important, and then within hospital, severe maternal and morbidity disparities. And what she found was that there were different themes between high-performing, where the quality indicators look good, and low-performing hospitals. And the first thing they did was one of the things they did was talk to the staff. Because, you know, nobody ever wants to accept that they have something to do with the disparity. And so the first thing, and I'm not sure I can clear, anyway, we'll try to work around our little, it's not a touch. Almost everyone who was evaluated said, I know I provide wonderful care, and I provide wonderful care and equal care to everybody I touch. That was the recurring theme. No one will acknowledge that you might look at people differently. depending on what they look like, where they come from. And having done maternity care for most of the years of my career, I can assure you that isn't true. There are people that you just have trouble with. Now, come on, let's be honest, right? There are people you have trouble with. The example I give in some of the things is, when the patient is brought in who's clearly homeless, hasn't had a bath in a few weeks or so, clothes are dirty, are you telling me that you're going to go run up there and spend time with some good human contact and staying close to them? Of course you don't. So we know that we are frail, and we have to think about how we distance ourselves from people that we cannot associate with, right? And so everybody agrees that staff communication is a really important factor. And yet they recognize too that we don't communicate as well with some patients and others. If a patient's first language is not English, one of the things that we will find is that, first of all, federal guidelines from 2001, the class guidelines, say who's responsible for providing an interpreter so that the patient can be evaluated in the language that they're comfortable with. It's our responsibility, right? But what happens when you use an interpreter? Well, you know, it just totally increases the time of the visit. So we don't want to do that. So what do? We cut short the history taking. So I'm just giving you some examples and say, in spite of this survey saying, oh no, we treat everybody the same, we communicate equally with everybody, we know it's not true. And therefore we have to be aware of this, right? And so then the other thing was, when they asked these, and this is again, women providing maternity, not women, clinicians, men and women, providing care to maternity women in this. They said, well, you know, if something happens and they don't do well, it really has nothing to do with what happened in the hospital. It's related to stuff in their life. It's, you know, they didn't take care of themselves, they were exposed to stuff in the community, they weren't getting enough sleep, they were drinking, they were smoking, whatever. So the initial assumption is, it's because something they did to themselves. It has nothing to do with anything that may be disparate the way I took care of it. And then, or else it's because we have staff shortages, and if we had more people, we could provide better care. I'm saying all that to say that it's very easy for us to immediately assume it's not our responsibility. Yet that's why we went into healthcare. That's why we went to medicine and nursing and pharmacy and physical therapy and psychology and whatever other social work, the other things we do. We went into to take care of people. So, and then on top of that, no one tends to analyze their data, their quality data, and their performance across race, ethnicity, or insurance source. We like to aggregate data because we know that has to do with our Medicare reimbursement. We know it has to do with whether we qualify for some of the awards that we'd like to be able to put up in front of our institutions. And that's the nature of how we do things, right? So what I'm saying is that we now realize that there are other issues that are factors, but they are factors that you cannot ignore, those that relate to our contribution. So there's an overall environment of healthcare that is where there are different contributions. Yes, there's the contribution of the individual, him or herself, and what they bring to the table, and the environment in which they have cared for themselves well or not. Then there is the environment of where they go to get their care. And we know that there are many different aspects of care related to big institutions. And then we also realize that there are other things that may very well influence that. So when it comes to, that's why cultural competence is such an important factor. Because cultural competence, it's not allowed to advance the slides anymore. So cultural competence is recognizing that culture imbues every organization in which we work. And you know what they say about, So culture, so there are different factors, and the culture has a lot to do with those factors. Great. Thank you so much. We'll just switch to that. So, and what we want to do is remedy any racial inequities that may be imbued in the culture. That means we have to acknowledge that they can exist. We have to be able to examine, use tools like registering what the patient's race, ethnicity, socioeconomic status, geographic location is. These are things that are not often done. Sometimes, most of the race, by the way, you know how it's identified in an electronic record? Looks like this. We don't ask the patient, how do I self-identify? Looks white, looks black. And we realize that's not accurate, as opposed to saying, how do you self-identify? We found, because we've done these studies, we don't do it. We said, well, we're too busy and it's obvious what they are. Is it always? Is it? And it's all black, black, and it's all white, white? I mean, would you consider all of yourselves the same? No, we have different ways in which we identify. So transforming how we look at those factors, educating ourselves about what the risks are, and then moving forward that way. So cultural, as I said, is those transmitted behavioral patterns, arts, beliefs, values, customs, all those things of a population that influence the lens through which we look at the world, and therefore how we make decisions. And healthcare has an organizational culture, and it affects the capacity to do things. It's almost like they say, if you ask a shoemaker to make a hat, it looks remarkably like a shoe. And to a hammer, everything else looks like a nail. So if you have only one view, and you have blinders, and you have one lens, you see things a certain way. And it's not until you get any diversity can you see that things may be different. So we all need these skills for cross-cultural care. We need to be able to do patient-centered care, care that's good for the patient, that the patient feels is good for themselves. Understand the issues about language barriers. Learn about who are your local community or cultural groups. Are you in the midst of an Amish population? Are you in a community where there have been a number of refugees that have settled? Who are your cultural groups? Do you take care of coal miners? That's a cultural group. And they have different risk factors. If you don't know your patient is a coal miner, you're going to miss things. I mean, going to medical school in Pittsburgh, as I did when I did, we had to know these things because if they came in short of breath, said, do they work in a mine or do they work in a factory and what kind? Is this going to be an obstructive lung disease or is this going to be a restrictive lung disease or is it going to be something else? Because you need to know these things and it may not be in the electronic record. So don't get me started on the electronic record. And you may have to add some of those things in that what box because there may not be a little check-off. And realize that there are principles of community-oriented care that are so very important. And I always say with patient-centered care, you know, it doesn't start with the computer screen. Patient-centered care actually starts with looking at the patient. And so often, as I've moved around, I've talked to other colleagues, they said, well, you know, so how did it go? I'll start with a little story and try, you know, I always end the stories and make sure I stay on time, okay? I had a patient that one of my colleagues who had cared for this couple for 30 years in Ohio said they moved into Pittsburgh because their grandkids are there. And they asked me to particularly refer them to a family doctor. I said, you should go to Jeannette. So they came. He's a retired attorney. She's a retired teacher, educated couple. And it took a while to get through because they had some issues. And this is a woman who was legally deaf. She had hearing aids in both ears, but she read lips. Was a cancer survivor. She had a number of connective tissue diseases. She had some severe osteoporosis and had some vertebrae that had collapsed over time. And she had myasthenia gravis. But when she got to that, I said, no, I can't take that. That's one I just don't see enough of. I said, I'm going to refer you to a neurologist for that particular one, and we will manage these other things. So I talked to one of my colleagues, and I said, can you give me a neurologist who's really good at myasthenia? Oh, I'm going to give you the top person in this part of the country. I said, great. So I talked it up to her, and I sent a message to this person. I summarized her record so that she didn't have to go through everything else, and I sent the patient off. So she came back a month or two later and said, so how did everything go? I said, you know, I referred you to the #1 person in the country for this. She turned to me and I always knew, can't look at, I need to look at her. And I looked at her, I said, how did it go? She said, can I have #2? I said, okay, what happened? And she said, well, she wouldn't take her eyes off the screen. And I kept tapping her knee and saying, and I had prepped all of this, and she says, and I know what she was doing, she kept saying, ooh, 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 because I mean, she really is very interesting. But that's not patient-centered care. And so she said, so I want number 2. So we need to be careful about that. And in the midst of all of this, we have dual pandemics. We know this. SARS-CoV-2 has really changed our environment. It has increased the hunger in our communities. We don't realize that for many young people, these children were getting their breakfast and their lunch at school. So when school wasn't meeting anymore, you had parents that were getting together to create these little food banks, until some of the schools decided that they were going to send the buses around anyway and deliver the food to the kids at the bus stop. But that took a while for to recognize that you want to know what's the socioeconomic status of your community. We also know that there have been significant differences. The Band-Aid has been pulled off of the inequities in our society with this pandemic. When you look at the Native American population, almost 3 times the higher number of cases, more than 5 times higher number of hospitalizations, and 1.4 times the number of deaths from coronavirus. And you can see whether it be Asian, non-Hispanic, or Black African American, or other Latinx communities, dramatic increases in the negative impact of this COVID-19 pandemic on their communities, largely because of underlying conditions, poor access to care, but something else. Differences in how they make a living. So it's not just, well, gosh, they should have had health insurance. Well, that's a nice thing to say. Sure, they should have health insurance. But if you're in a front-facing occupation, you drive a school bus, you are a waitress in a restaurant, you are a healthcare worker, and you are already, you can't do those things remotely. So you've heard all the discussion, but that the people of the communities of color disproportionately have those type of front-facing jobs. And then we've seen dramatic increases in anxiety and depression during COVID-19. So just looking at 18 to 29-year-olds, they were able to see dramatic increases in the number of anxiety and depression by the month in 2020. And you can see this. And it's across all groups and age groups and time periods. Black and Latinx communities reporting the highest rates of symptoms of anxiety disorder and depressive disorder. And then on top of coronavirus, we've got racism. And that's a pandemic too. And what we realize is all of these things are important for those of us who are in GME training programs, because the ACGME has worksheets and all kinds of standards that it wants followed by those of us who are managing or engaged in training programs. And it requires that we have a knowledge of common patient safety events. Well, I'd say coronavirus and this pandemic is a patient safety issue, depending on what you do for a living, right? If you can't put yourself in a COVID-free bubble for the duration of the pandemic, then there are some safety issues here. And making sure that there's a discussion about not only the patient who's sitting in front of you, but all of those with whom they come in contact with, and those of us who care for families, who else is in the family. So that if you have one person who's staying at home, but the 2 other people in the household are in COVID-facing or front-facing, you have to know that. And multi-generational households are more common amongst people of color, okay? So all of these are things that are also, even if you don't care about it for one other reason, realize that these are ACGME metrics that we have to be able to pay attention to. And furthermore, there's a whole idea of trust and mistrust. We know that trust is a crucial element in patient-physician therapeutic alliance. I personally have said, not going back to that person anymore. Has nobody here ever made that decision? Come on, I won't make you raise your hand. I'll raise my hand for you. If there's somebody that you don't think is listening to you, is not paying attention to you, gets key elements of your history wrong after you've reminded them a couple times, well, that lack of trust will send you out the door with no plans of returning. And so mistrust of the health system affects the patient's use of services. And then what happens, you say, well, I don't know why this patient goes. Inconsistent care, they seem to be doctor shopping, they medicate themselves the way they want to and all, and they all want lots of referrals and diagnostic tests. First thing is that bad patient. Boy, this patient is a pain in the And we have all these different ways of describing it. Sometimes the question is, you're clearly concerned about something. Can you share with me what it is that makes you so anxious? It will take a few more minutes for the encounter. But when a patient doesn't trust you or the system or the last person they saw in the same office that you're sitting in, you don't know what the reason is why they don't trust you necessarily. That means that their demands will seem disproportionate to what's going on. And some of this is the legacy of the Tuskegee study. And this is something that, again, for those of us who had a background in the South during this time, this is a study that was approved by the U.S. Public Health Service that ran for 40 years. That was reported on at the AMA meeting each year. And colleagues listening to these reports talking about this epidemiologic study of black men with syphilis. Long after they had identified that penicillin was, Tuskegee study started in the 1930s. Penicillin was identified as being a good antibiotic in the mid-1940s. This study was presented at every AMA meeting for years, and none of the other physicians in the room listening to this said, excuse me, why are you not offering these participants penicillin? Which in and of itself says something about the culpability, not only for the federal government, that should have oversight, the investigators themselves, and there are a lot more details that show you how purposefully treatment was restricted from not only the men, the 400 plus men that were participating in the study, but their families. Everybody was at risk for that. So that legacy continues. And actually recently, the University of Pittsburgh elected to take the name of the Surgeon General who approved and monitored this heroin off the School of Public Health, because they realized that this man should not have a building named after him after approving this and not seeing what was going on. So the big question is the system trustworthy? Is your practice trustworthy? Is your group trustworthy in how they manage a diverse population of patients? We know that when there are racially discordant doctor-patient or clinician-patient encounters, they tend to be shorter in length. They don't have much of a positive effect. They're definitely not patient-centered, which means there's not a lot of listening taking place. They don't tend to answer questions nor about either the treatment or planned treatment. Less health education, and there are lots of data on this. You can look at data when it comes to osteoporosis in women and who gets educated about what are the things that impact your bone density in a woman. It's different if it's a white woman versus a woman of color. You see these data when it looks to how pain is treated in emergency departments. Multiple studies have been done of that. And now they're even doing studies of pediatric populations of pain. And we don't treat pain the same in culturally different groups. We don't spend as much time building relationships between the patient, which again takes time when it's a racially discordant encounter. And therefore, we don't allow the patients to be a part of the decision-making for their care. And we see that these result in state variations in healthcare quality. So there's been some good state data. And for example, this particular map shows the overall quality of care by state. So let's just look at Pennsylvania because it's easier to see. Maryland's right tucked in there. Pennsylvania's blue on this one. Overall quality of care, you see it's blue, first quartile, highest, the best. Looks good. And green is third quartile, so it's not too bad. Okay, that's Maryland. However, if you break it down by disparate quality, depending between minority groups and majority groups, Pennsylvania and Maryland drop. And Pennsylvania drops to the lowest. And that shows that if we can make, what do they say? You can make numbers tell you to say anything you want them to say. You can measure the statistics that you want to measure. But if you look at, when you break down those metrics and those statistics, and you break them down by race, ethnicity, socioeconomic status, census tract for the population you serve, what you may find is something that's distressing, that you're not actually providing equal care to all. And some of it's related to access. We always say, well, if they had health insurance, they'd have better access. That is true. The access would be better, but not necessarily equal. If they had a usual source of care, which means if they could tell you, I get my care at such and such a practice, or I get my care at such and such a clinic, and my doctor is so-and-so. Those people do better than those who can't. But if they had trouble seeking care, if they hit a telephone tree every time they call, or they have to do it online, there are a lot of people who will never get care. How about the vaccine issue, disparities that we've seen? Everybody says, well, they don't want the vaccine. I've done some work and done some at the national level and working with some vaccine information sessions. And I'll tell you right now that for many, it's not that they don't want the vaccine. They can't navigate the system. I personally spent 2 or 3 weeks trying to get, and I had registered myself in 4 different systems, trying to, before I could find a place to get a vaccine myself. And I consider myself fairly literate. And it was hard. And one of them, I just said, I'm going to put this online, I'm going to have the phone there, and I'll wait. 2.5 hours later, I checked in, they said average wait time greater than 1 hour. Now, if you're an hourly worker, you can't do that. You can't do that. If you're driving a bus, you can't do that. So we realized that having insurance is just the beginning. Largest disparities, poor people. Poor people come in all hues. If you are poor, you have a hard time. And poor people tend to be uninsured at 3 times the rate of those who aren't poor. Black people. Black people have the largest disparities between them and whites. And there again, it's not only the children, they don't get in for their routine well-child appointments, and then patients with, the adults with chronic illnesses have a hard time. Hispanic populations all over the region. You'll find those, again, have a hard time, serious disparities. So there's a real social injustice here is what we're thinking. Because the poorest people have the highest levels of illness and premature mortality. But poor health is not confined to those who are the worst off. Look at Serena Williams. Look how they're like. I would say she's not considered poor or not well off. But what we've seen is just differences in the way people are treated when they say, I don't feel well, I'm having trouble breathing, this has happened to me before. And yet we make decisions about what that means and we don't respond. We're not listening to the patient. So it happens often by the color of your skin or your socioeconomic status or what part of the tracks you live on, all those sorts of things. And there's a social gradient. The poorer you are, the worse your health care is. I just showed you that particular. And these social determinants of health absolutely influence care. And the crazy part is only 20% of health is really something we can take care of as folks who are health care providers. There are so many other things. Behaviors take up about 30% of it. Physical environment is about 10%, and then all those socioeconomic factors here. But it's all a big system, and if we don't spend time talking to patients, and we don't educate them about their behaviors, and we don't offer them interventions to help get their weight down, to help them to stop smoking, to help them to moderate their alcohol intake, then we have also abdicated our responsibility to help them with those behavioral aspects of care. So what will you do next time you identify health disparities? Well, I would submit that these inequities begin before the patient enters the hospital. It's our responsibility at the primary care ambulatory level. And I always do this when I think of teams. Sorry, I'm just always nervous. So things don't stand here. But we have to do things as teams, okay? Just saying. And teamwork means that you will see, it will help you to make sure that other people are helping you respond to these inequities that you see. And Diana Lomberg, Association of American Medical Colleges, has been talking about allyship. We have to start developing allies, because allies help us to see whether we are unconsciously biased, where that's implicit or unconscious bias, meaning a positive or a negative mental attitude towards a person, thing, group, just something that you're not really aware of. And those mental associations actually shape how you respond, what you do. But, if you have privilege, equality looks and feels a lot like discrimination. You ever hear people say, that's not fair that this person is here and not my buddy? Because I always had the opportunity to get my buddy into these positions. I always had the opportunity to get my child to be able to do this. So when you've always had that privilege, you actually don't want to see a system that doesn't give you the same advantage. And so privilege is that social capital that's distributed amongst people where the amount of, that each person has at their disposal is actually not dependent on how hard they work. It's dependent on their identity. And they believe that they should be exempted from any liability or other things because of who they are, that identity they have. And so there's thinking of the subtle acts of exclusion, where there are these microaggressions that some people make some people feel defensive. It just describes the way we can push certain people to the margin by these subtle things that we say. And I think one of the best descriptions of this is by an educator, Dr. Darrell Sue, who did a wonderful book that came out in 2010 called Microaggressions in Everyday Life. And he says there are 3 different categories. There's the micro-invalidation. It's unconscious, and there really isn't intent to harm. And they actually, sometimes they make it seem as a compliment. Well, you know, people like you don't usually do as well as you've done. Is that a compliment? You know, there's little things that are said. Then there are the micro insults. Those are subtle, and they can be unconscious. They are not intended to harm, but they convey rudeness, insensitivity, and demeaning your identity. Then there are the ones that are the micro assaults. They're explicit, they're conscious, and there's an intention to harm. And other people call it this old-fashioned racism, old-fashioned discrimination. A lot of times it's done privately, but every once in a while it's actually done publicly by design to sort of put you in your place. So tomorrow, what do you do? What you can do is, how can I be an ally? By being willing to make mistakes and then try again. And say, you know, that came out wrong. I can see it on your face. Can you tell me what I did or how I could do it better? That means really being humble and say, I know I messed that up. And I know I messed that up. And sometimes we just don't want to say that. But anybody here never made a mistake? Because tell me how you did that. Because we have to be able to say, I make mistakes. Realizing that sometimes that mistake means I have to get into an uncomfortable conversation. I'm not going to feel like I'm at the top of my game. It's going to be kind of complicated. But if you don't do it, somebody's really hurt. Acknowledging and recognizing, you know, I've never had to worry about this because it's always gone really well for me. So sometimes you have to acknowledge that you've been privileged. Sometimes we have to listen more and speak less. And sometimes we have to ask somebody in what we call, sometimes called a minoritized community, to sort of tell us what really worked better. Sometimes we won't necessarily be able to figure it out on our own. And we have to be willing to accept criticism, and that's hard. That's hard. None of us got here because we didn't feel a certain level of confidence in our competence. Okay? And recognizing, don't expect to be congratulated when you finally figure it out. Okay? Sometimes we want to be rewarded for being really good. Sometimes we just need to get through it, okay? Sometimes we need to look for anti-racism training, and there's more and more of that coming out. Because what it does is it says, remember the journey that these people have gone through. Remember 1865. Remember 1921. Remember 2021. Look at it, and recognize that that's what this is this person's lived experience. So take that into account as you are making some decisions with them. And then bystander training is really important. We're spending a lot of time, some people call it upstander training, which is you're there, this didn't happen to you, but it happened to the person you're standing next to. Are you going to sit there and do nothing and say nothing? Or are you going to say, wait a minute, I think something happened here, can you help me with this? Sometimes you can be not aggressive, but make it clear that I think something bad just happened. Can you explain why you just said that? Don't be threatening. Take responsibility and say, you know, I think that we need to step out for a little bit. Sometimes this happens in a patient's room. Sometimes we have to say, you know, let me just take a moment and we're going to step out and we'll come back. So the goal is not to shame people, but it's also not to let those situations go by. And if you don't do something at the time, the harm to the person who's the victim actually lasts longer and goes deeper. If they know that you're trying to make a difference, it has so much less of a negative impact. And sometimes when you're in the teaching position, you have to say, well, what could you have done? Could you have said that differently? Could you have said that differently? I have lots of examples, but I'm running out of time. And then redirect something. You know, I think that maybe we ought to look at this a little bit differently. Paraphrase things. Have you considered the impact of what you say? Teach with I phrases. You know, a lot of times people say, well, that's not it. And I'll say, I felt uncomfortable when you said that. Don't argue with me. I felt uncomfortable. Use the I phrase so they can't argue about whether it happened or not. And then sometimes you have to document. Sometimes people just don't learn. And you have to document. This person has a hard time with homeless people. Every time they got a homeless patient, they mess up. They have a hard time with non-English speaking people. Every time they're with them, they mess up. Because you don't, first and foremost, we need to protect the patients. We need to protect the patients. Then we need to protect the learners. Then we need to protect each other. So sometimes you have to actually document this. Realize that equality is what we've been talking about, where everybody gets the same benefits. They all have the same size box, right? Equity is when you realize that this person, for one reason or another, is behind. Maybe they need 2 boxes. But justice is when you say, wait a minute, these are barriers that don't need to be here. Let's take this wall down so they can actually see. But I think we need to think about it. Equality, equity, justice, and how are those different? And all because the health of the community is a shared responsibility of all its members. And we have to do this. Many of these things are not going to be in the traditional domain of health activities. It's not drawing blood, it's not ordering a test, but it's showing the person with whom you're speaking that you understand the background that they come from, okay? And you realize that this is something that that you need to address. And all in all, we have to be humble. I talked about cultural humility earlier. Melanie Turbalon and Jan Mary Garcia, 2 pediatricians at Oakland Children's Hospital, introduced this theme back in the late 90s. And it is so true, realizing that it has to be a lifelong commitment to self-evaluation and self-critique, so that we make sure we're trying to address those power imbalances that we see between those of us who are clinicians and those that we have committed to serve. And then developing those mutually beneficial partnerships with our communities so we understand and we have a good thermometer about that. And moreover, avoid the current crisis of compassion. I've actually been external evaluation teams of misadventures of things that have happened. And then I had to interview folks about the bad outcome. And one thing that came up was, well, it was my fault. And if this patient had done this, that. Let's first of all be compassionate. Let's be compassionate. Let's not get our backs up because we think somebody's pointing something at. Let's think this person had a terrible outcome. Let's avoid this crisis of compassion. When we're tired or we're busy, it's hard. Realize that we have to have good leadership in our organizations. We have to be patient-centered. We have to ensure that we are all culturally proficient as clinicians, recognizing those historical factors, I say. Identify individuals who have offensive behavior, who don't seem to learn from didactic teaching. Pull them aside and put them on notice that you're watching them. Don't order another group cultural competence session. You know how that happens? Okay, we're gonna educate everybody. No, we have one thing. Pull this person aside and say, you're the problem. You're the problem. Let's talk about how we can help you. Okay? And then incentivize a team approach. I told you about teams. Teams are able to do more and in a more diverse fashion, and they balance one another, so one person's weaknesses is offset by another. Let's do it as a team. Incentivize and embrace your team. And then look at your mortality and morbidity reviews, and look at not just the things that were in the EHR, the X-ray results, the labs, what were the quality indicators. But let's ask about all those other things that are not as easily or usually documented. Keeping together is progress. Working together is success.
I think we have a little bit of time for questions. Go ahead, Matt.
Thanks a lot. That was great. And as we work to educate ourselves as faculty and educate our residents in these issues, I struggle sometimes to understand where our lane really is. Cultural competency, all the things you talked about on the individual, personal, patient, clinician level, really important. But you may remember that discussion a while back when the emergency room doc started speaking out about gun violence and the gun people said stay in your lane. What is our lane? Do we encourage ourselves and our residents to attend city council meetings where they're discussing housing options for the poor? You know, I mean, it's a lot for us to assimilate, for our residents to learn. But I think studies have shown if you don't do the systemic work at the individual level, you can only make so much difference. So.
Thank you for that question. That's a great question. And the reality is, I think if nothing else, this COVID pandemic has shown us we can't just say, well, when a vaccine comes, we'll learn all there is about it and we'll tell you about it and make sure you get it. We have to get out of our lane and say, you know, this is the daycare center where our kids go. People need to be wearing masks. They need to be washing their hands. A lot of people say, well, that's not your lane, that's public health. And we have kept medicine from public health for too long. Or when you know that somebody's working like in these meat packing plants and they are shoulder to shoulder and there are no masks and they don't have time for bathroom breaks and all, you would say, well, that's corporate. That's the work environment. We shouldn't say anything. I say our lane is anything that influences the health of those who provide care. And now that doesn't mean every one of us does everything. But I think most of the professional organizations, I know that the American Academy of Family Physicians is having special sessions on advocacy, teaching young people and us older people, we call ourselves teenagers now. You know that? Anyway, even as teenagers, we have to learn how to speak up about things. And that's what the bystander, upstander training is. We can't just stand there. We have to say, wait a minute, I'm uncomfortable with this, something just happened here, and it wasn't, that's not particularly eloquent, but you know something? It gets the message across. That was not a good comment, and that wasn't a good encounter. So, we only have so many hours in the day, so we can't do it all, but if you go to take care of this one, then I'll assign you something else, and we'll divide it up. That's the teamwork again.
Any other questions?
Hi, I'm LaKenya. I'm new here to Maryland, soon coming up on a year, I can't believe it, in September. But I've been in the healthcare field, not as a clinician, but on administration side of it. So I'm sitting here with all these nurses and doctors and senior leadership that I'm just trying to figure out, okay, so where do I fit in? Was it only for the clinical? But one of the things I'll take from working in a big enterprise, I worked in New York, I worked for New York Presbyterian, which is a massive, big institutional organization, should I say. And just thinking about what you said about getting to know your community, culture, groups. I think it's very important. Even though I'm on the administrative side, I happen to be privileged because of the positions that I held to sit in with a lot of leadership and also with residents, because I worked with residents for at least 4 or 5 years. Not only surgical residents, but podiatry residents and medicine residents and GYN residents, right? And one thing that I am a watcher because medicine is so interesting to me. And one thing I know is that sometimes you have patients and you have the clinicians who work with patients, but when your patient comes in, especially when you said trust, you know, being of a different ethnicity, you know, when you say trust, not just talking about a patient, but if it was me going to see my doctor, you don't only go there to tell your doctor, oh, my knee hurt. Sometimes you get into different conversations about what's going on in your neighborhood, what's going on in your home, why you're under anxiety, why you feel depressed. This is your regular PCP you're talking to. And then I know from being in an institute like a hospital, there are so many. If you go to just the clinic, then you may only have your PCP. But if you go to a hospital entity, you have the PCP, you have the psychiatrist, you have the social worker. There's so many. A patient is like coming to a mall. You know,
I think one of the things I think you're aiming for is the fact that so often at different levels of roles in healthcare facilities, each of you have a way in which you can participate. For example, I looked at my front desk person as critical as ever. My husband used to say in his practice, he says, nobody can work for me who doesn't know how to smile. Because if they come in and they meet a grumpy person at the front desk, they're already furious by the time they get back to their room. So that you can be the front desk person, you can be the person on the phone making appointments. And when I told my front desk people, I said, you know, if this person is late, ask them whether there's something that they really need to be seen before you tell them, you gotta reschedule, you're late. You say, well, if you really need to see it, are you willing to wait till the end of the day? Or things as if, some people, you know, are chronically late, give them a different appointment time. We do that all the time. Say, you know, she's not on time, so give her a time an hour earlier. And we'll get her in. By the time she finally gets here, she'll be on time. So you do things, and that means you're part of the team. And everybody is part of the team in order to take care of the patients who have their own unique issues. So I think everybody's valuable because we all work together.
Thanks so much. Dr. Southpaw is going to be able to join us in the residency for the rest of the afternoon, and we're looking forward to that. I'm sure if you had other questions, you could stop by up at Suite 200. I am just honored, Jeannette, to have you be here, and I learned something new from you all the time. I'm reminded of the concept of leading from any chair, leading from any place that we sit, and thank you for being one of those leaders that wants us to come back for more. Thanks. Have a wonderful one.